it's now my pleasure to introduce Dr. David Jackman, who is one of the senior physicians in the Lowe Center for Thoracic Oncology, as well as the medical director for clinical pathways for the Dana-Farber. And he will be trying to cover all of lung cancer for the next 30 minutes. So please give him your attention. Thank you, David.
Wendy, thanks so much. And for all those listening in, thank you so much for attending. It's really my pleasure to be here with you. Obviously, I wish we could be together in person. These are my disclosures, with More Health, which is a telemedicine company. Today, I want to talk about 5 specific things. I want to talk about the epidemiology of lung cancer, want to address clinical presentation, diagnosis, and staging. I want to talk specifically about lung cancer screening, which was again in the news over the last 2 weeks. I want to talk about an overview of lung cancer therapy. And then finally, want to provide some sample questions and cases for your study. So we'll start with epidemiology. Lung cancer is the leading cause of cancer death, and it isn't close. As you can see here, colon cancer, pancreatic cancer, and breast cancer, which are the next 3 highest causes of cancer-related death in the U.S. When you add the number of deaths from each of those annually, you basically get the number of deaths from lung cancer. And this is despite the fact that lung cancer's mortality has improved. It used to be about 162,000 deaths per year. So this is despite a significant improvement in how we're doing. This is an important slide for a few reasons, and something that I want you to notice. In the upper right-hand corner of the slide, you see a little pencil. And on those slides within my deck that I think are important for internal medicine board review, I've put that little pencil icon there so that when you're studying at the last minute, it can draw your attention to those things that I think are important. I'm here, want to bring your attention to a few things: that the risk of lung cancer is proportional to both the amount and duration of tobacco smoke. And also that cessation lowers risk, but it never quite returns to that of a lifelong smoker. As you can see here in these various lines of those patients stopping their smoking at various ages, it never quite gets to the blue dotted line that is the baseline risk of lung cancer in lifelong non-smokers. Non-smokers, in fact, account for about 10 to 20% of lung cancer cases in the United States. And why do we see them? Well, a number of reasons, but the 2 most common risk factors are secondhand smoke and radon, with outdoor pollution and occupational exposures explaining some other causes in these non-smokers with lung cancer. Clinical stage, and we'll get to this more in the later part of the talk, but clinical stage, the extent of the cancer, how big the mass is, whether it involves lymph nodes, whether it's spread distantly to other organs, is the most important prognostic factor in lung cancer. And one can see how potential prognosis drops quickly as you move through the various stages. Also, and incredibly soberingly, in addition to the prognosis for late-stage lung cancer, is the fact that more than half of patients are metastatic at the time they're diagnosed, with 55% of patients in one analysis from SEER 2000 being stage 4 at the time of initial diagnosis. It's important to think about the impact of lung cancer histology. You know, it's not enough in this day and age to just say I have lung cancer. That we think about these things as very different cancers histologically, and also in terms of how they behave and how we treat them. And so from a 10,000-foot view, we divide lung cancer into both non-small cell and small cell, with small cell taking up a smaller proportion as the years go by. There's some suspicion that this may be due to the introduction of filters into cigarettes that didn't reduce the risk of lung cancer, but it changed the size of particles that were making it down into the airways. Some of the larger particles that land centrally were being filtered out, some of the smaller particles getting further down into the airway, and those would tend to be the non-small cells, the adenocarcinomas. When we break down non-small cell lung cancer into its constituent histologies, we see that adenocarcinoma and squamous cell carcinoma are the 2 most common types, followed by large cell, other specified things like a sarcomatoid lung cancer, and then not otherwise specified. And the thing that I want you to remember for your tests is this table here. When we think about the three most common histologies, small cell, and then the two most common non-small cell, squamous and adenocarcinoma. I want to talk about a few things. The most common location, the small cell and the squamous tend to be central, whereas the adenocarcinomas can be central or peripheral. But when you see something that's more peripheral, there's a better chance that it's an adeno, though it still could be one of these two other things. In terms of the chance of finding these histologies in a non-smoker, a never smoker, it would be exceedingly rare to find small cell in a never smoker. Small cell lung cancer is the kind of cancer, of any kind of cancer, that is most closely associated with cigarette smoking. Over 95% of patients with small cell will have some significant smoking history. Squamous cells also are rarer in patients who have never smoked, whereas when we see non-smokers with lung cancer, it tends to be adenocarcinoma. Many of the targetable genomic alterations that we're going to talk about later, the ones for which we have approved targeted therapies, tend to be found in adenocarcinomas, and we don't see these as frequently in squamous. And we haven't really found any druggable targets or consistently druggable targets as yet in small cell lung cancer. And then in terms of paraneoplastic syndromes, and we'll touch on this later as well, small cell has been associated with a number of things, including but not limited to SIADH, paraneoplastic Cushing's, and Lambert-Eaton syndrome. And squamous cell lung cancer is classically associated with hypercalcemia. This table is worth knowing for internal medicine boards. I want to talk about lung cancer screening, really talk about the ABCs, the audience, the benefit, and the calendar or the cadence. So first, the audience, who should be screened? And so if you'd asked me this question 3 weeks ago or before that, it was asymptomatic adults aged 55 to 80, and who were heavy and recent smokers. That is, they had to have smoked at least 30 pack years, and they have to either currently smoke or had to have quit smoking within the past 15 years. These numbers were largely based on the criteria from the National Lung Screening Trial that was conducted and then published in the New England Journal. In terms of the benefit, two major trials. There have been others, but these are the two that are most frequently cited because they are both large randomized trials. One conducted in the United States, the National Lung Screening Trial, which showed a 20% decrease in lung cancer mortality and a 6.7% decrease in all-cause mortality. And the Nelson trial, which was conducted in several countries in Europe and showed a similar 26% decrease in lung cancer mortality, both associated with low-dose annual CT scans. The U.S. Preventive Services Task Force, based on these studies, has made lung cancer screening with a low-dose CT a grade B recommendation. In terms of the calendar, the cadence, it's an annual low-dose chest CT, and screening should continue, or that is, it should be discontinued once a person has not smoked for 15 years or develops a health problem that substantially limits life expectancy or the ability or willingness to have curative lung surgery. So if a patient ever gets to the point where they're either too old or unwilling to move forward with consideration of biopsies and surgery if we found something, if we're not going to act on the results, then there's not a great point in getting it. Now, some updates. Within the last 2 weeks, the U.S. Preventive Services Task Force changed their recommendations. They lowered the age to begin screening from 55 to 50, and this is in some ways easier to remember because it coincides with other screening things like, say, colonoscopy. And they lowered the number of pack years to be eligible from 30 down to 20. In making these two changes, it's estimated that they have doubled the size of the population that is now eligible and recommended for lung cancer screening. And so this is an important part of your practice as we go forward, because when we look back, and I mentioned that annual lung cancer deaths had decreased from about 162,000 to about 135,000 per year in the US. We think that a significant amount of that is from lung cancer screening gaining more widespread adoption. And so we certainly want to encourage this. I think a challenging part of any sort of screening is, what do I do if I find something? So I want to call your attention to something called lung rads, which is a relatively more recent effort with guidelines published last year. And this is different slightly than the Fleischner guidelines, which were guidelines for what to do if one incidentally found a lung lesion on a scan that was performed for an unrelated reason. So a patient was getting hip surgery and such, and incidentally was found to have a mass. That's different than specific screening population. And so the lung rads I've summarized in the next few slides. I don't think that it's necessary to memorize all parts of this, but I'm going to point out a few things. The main thing, though, that I want to emphasize between lung rads for screened patients and the Fleischner guidelines for incidental findings is, you might recall that the Fleischner guidelines call for a difference between a high risk and a low risk patient, because these are incidental findings that can happen in anybody. Whereas there's no such distinction in lung rads, because if you're being screened per the criteria we already discussed, you're already considered an at-risk patient. And so I've divided the lung rads, as with the breast BI-RADS system, has a number of categories, and there are these early categories that relatively correspond. Category 0, or lung rad 0, being incomplete, need more information. Category 1 being negative. Category 2, these small lesions which carry of what is felt to be a low risk of malignancy. And so there's nothing different recommended aside from continuing annual screening. I call your attention to the next slide, because this is where we start to get into kind of that fine line of, when do I worry, when do I not worry? And so certainly when we get to category 4A, this is where we want you to start worrying. And so with the magic number here really being greater than 8 millimeters, or growing nodules, things that make sense, or new nodules within this setting. And so wanting to think about these, because this is when you move to a more rapid follow-up and or a PET-CT, particularly if there's a fairly large solid component. And then finally, these are the very worrisome things. And I think that, it's easier to remember than, well, yeah, these are things that kind of make sense as, oh, well, it's bigger than 1.5 centimeters and or new and growing. These are the kinds of things that I want to get PET-CTs or get biopsies and such. So I want to move on to clinical presentation, diagnosis, and staging. How does lung cancer present? It can present in any of a number of ways. As with many cancers, there can be more generalized symptoms like fatigue, weight loss, or night sweats. Or there can be specific focal symptoms related to local destruction, obstruction, or replacement. And I've divided these kind of into 3 categories. Pulmonary symptoms that we see frequently, things like cough, shortness of breath, hemoptysis, or SVC syndrome, particularly with some small cells. We can see stuff related to bone metastases, focal bone pain, fracture, or cord compression in more serious cases. And then finally, we can see symptoms related to brain metastases, like focal CNS symptoms, seizures, or altered mental status. These obviously aren't the only symptoms that we can see, but they are the most common. We can also see paraneoplastic syndromes that we've already alluded to, SIADH, Cushing's, hypercalcemia. And so lung cancer staging. So every cancer is staged with a different set of studies, different set of scans, and it depends on the natural history of that cancer. For lung cancer, the most common sites of metastasis are the brain, the lungs, the lymph nodes, in the mediastinum, the liver, the adrenals, and the bones. And so we need staging scans that are going to account and cover for all of these areas. And so all patients with a new small cell lung cancer, or all non-small cell lung cancers that are looked to be stage 1B or higher, require brain imaging. And the key here is it needs to have IV contrast. brain MR with GAD, or CT head with IV contrast. An I- CT done in an emergency room after a car accident is not going to be a good study to find small brain metastases. We need a CT chest with IV contrast, and the importance of the IV contrast being to better allow us to delineate and differentiate the mediastinal lymph nodes from the vasculature. IV contrast is also critical in being able to look for liver metastases. It's incredibly hard to find liver metastases, especially smaller ones, when IV contrast is not used. When you specify that you're getting a CT chest for a lung cancer patient, they will automatically drop it down to include the liver or the adrenals as part of the chest CT. We also need to evaluate the bones. This is done either through PET CT or through a bone scan. The PET CT obviously will also give you information about this other set of geographic areas. In addition to radiographic staging, there are a number of lung cancer patients who need mediastinal staging. Why do we need mediastinal staging? For what looks like early stage disease that is potentially resectable, we want to determine whether there is involvement of mediastinal lymph nodes, because if there is, we generally would not take these straight to the OR, but would rather recommend neoadjuvant, that is pre-surgical therapy prior to considering surgery. For patients who look like they already have involvement of the mediastinum, it's important to determine which nodes are involved and which are not, because that can potentially impact the shape and size of the radiation oncology field. How do we do this? We can do this either through cervical mediastinoscopy, through bronchoscopy and endobronchial ultrasound with biopsy, or through lymph node dissection at the time of surgery. But one way or another, in patients who fit these criteria, it is important to do this. I want to take a slide to talk about making a lung cancer diagnosis, the purpose of doing it, the means of doing it, and some additional pearls to consider. First, what's the goal of doing these biopsies or doing this, getting these specimens? Obviously, to make a safe, timely, and accurate diagnosis. We also want to obtain sufficient tissue for subsequent biomarker studies and also potentially for clinical trial eligibility. And this is no longer just the stuff of academia. That some of the greatest strides we've made in lung cancer therapy are through things like targeted therapies that require having sufficient tissue to study one's cancer. And if we don't get enough at the time of initial diagnosis, then we just have to subject a patient to additional biopsy, which we don't want to do. So it's important to get it right at the beginning. And then we want to confirm spread when applicable, and I'll get to that in a little bit. Means we can do this through CT-guided biopsies, through bronch or EBUS or mediastinoscopy, as discussed on the last slide, thoracentesis or other drainage, through a surgical procedure, or through other types of incisional biopsies and procedures. Some additional information. First, it's important to know that bone biopsies are usually inadequate for biomarker studies or for trial eligibility. When a path lab gets a bone biopsy, they have to decalcify it. And the decalcification process that bone biopsies undergo denatures the DNA and makes such subsequent biomarker studies difficult or impossible. Finally, I want to mention that if there appears to be only one single site of spread, that is, if someone has a lung lesion and an adrenal metastasis, it's important to biopsy the adrenal metastasis to make sure that it actually is tumor and not just an adrenal adenoma, because we'd hate to resign somebody to say you've got metastatic incurable disease if in fact that's not cancer and one really just has a local lung cancer. So if it's only a solitary site of metastasis, it's important to prove that that is indeed metastasis. As promised, wanted to get back to the paraneoplastic syndromes and just wanted to touch base about with which histology they're associated and what the mechanism is, because this is another thing that often finds itself on internal medicine boards. One of the ones that comes up most often is hypercalcemia, and recognizing that there are different mechanisms for hypercalcemia in different patients. And the hypercalcemia of some lymphomas, for instance, is different than the hypercalcemia associated with squamous cell carcinomas. In squamous cell lung cancer, it's usually one that's mediated through PTH-related peptide. In small cell, we talk about SIADH, mediated through antidiuretic hormone. Cushing syndrome, which is due to ectopic ACTH production by the tumor itself, or in Lambert-Eaton, which is caused by antibodies against voltage-gated calcium channels. I'm going to stop for a second. Cushing syndrome, paraneoplastic Cushing syndrome in small cell lung cancer can be very severe. And these patients often die not directly of their cancer, but actually of infection related to the extraordinarily high production of endogenous steroid that results from the Cushing syndrome, and thus rendering their immune systems weaker. Finally, thymomas, which are not largely covered in any of the talks that you get, but since they're in the chest, I thought I'd mention them. Something that's strongly associated with thymoma is myasthenia gravis, which is related to antibodies against nicotinic acetylcholine receptors, more rarely pure red cell aplasias. And so the ones that are tested most often on internal medicine board reviews would be the hypercalcemia of squames, the SIADH of small cell, or the myasthenia gravis of thymoma. When you see one, you need to think of the other with respect to thymoma and myasthenia. Finally, I want to provide an overview of therapy for lung cancer, and from the perspective of what a non-oncologist needs to know. You don't need to know the nitty-gritty of drug A versus drug B, but I want to give a general overview in stage 1 disease. So what is that? It's just, trying to not get bogged down too much in the details, but stage 1 is a small lung mass without spread, and we cut these out. In stage 2, it's either a larger mass or it involves local or hilar lymph nodes, and we cut these out as well as considering adjuvant chemotherapy afterwards. In stage 3 non-small cell, which is really some involvement of the mediastinum or a much larger mass. We think about these with multidisciplinary therapy. No one thing is enough here, and so it might be chemo followed by surgery, or chemo plus radiation, or sometimes chemo and radiation followed by surgery. And there's lots of different approaches, but the take-home message is that they need to see docs from different disciplines. And finally, stage 4 is when it's spread contralaterally or distantly and or involved a malignant pleural or pericardial or other effusion. And treatment here is palliative. That is, it's not consistently curative, but it's still incredibly important because we have the opportunity to improve both length and quality of life. In small cell lung cancer, the staging is generally thought of as blunter, really limited or extensive, depending on whether one can encompass all of the disease in a manageable radiation oncology port. And so if it's limited to one lung plus regional lymph nodes such that it's encompassable in a feasible radiation port, then it's chemotherapy plus radiation, much like stage 3 non-small cell. Whereas extensive stage small cell, again, is like metastatic non-small cell, and that is that its treatment is palliative, but has the opportunity to improve quality and quantity of life. I want to focus again on the early stage stuff. We said we cut these out, and we do. And we want to really get across the message that anatomic resection is the gold standard. It's not enough to just wedge the thing out. We want to take not just the mass, but also its lymphatic drainage. And we do so by taking a lobe, or in some cases, if it's crossing the fissure, taking out multiple lobes on the right, or on the left, doing an entire pneumonectomy. For frailer patients, yes, we can consider other alternatives like wedge resections, radiation, or ablation. And these are important, though they're not considered equivalent to a good surgery. Want to talk about the role of radiation in lung cancer. We think about the radiation as curative in early stage disease, and those patients who, for whatever reason, can't go to surgery, well, then radiation still offers a potentially curative approach. Or as mentioned, for locally advanced disease, stage 3 disease, we can think about radiation either as neoadjuvant, chemo radiation, and potentially going to surgery later, or chemotherapy and radiation itself as being a potentially definitive and curative strategy. In addition, we think about radiation for palliative uses to address an urgent symptom like cord compression or SVC syndrome, airway obstruction, to palliate for a painful bone metastasis, or for brain metastases when our chemotherapies don't reliably get into the brain sufficiently. And so we need to think about radiation to manage brain metastases. And then more recently, we've thought about other roles for radiation that aren't curative, but aren't purely palliative either. And so we think about prophylactic cranial irradiation in small cell because of the high frequency of spread of small cell to the brain. We've seen a role for consolidative chest radiation in small cell for patients who are doing well on first-line chemotherapy. There's actually been a survival benefit in some patients who get consolidative chest radiation thereafter. And then finally, more and more, we're thinking about focused radiation in what we'll call oligoprogressive disease. That is, someone's on a targeted therapy. It's working everywhere except one spot starting to grow. And so instead of throwing the baby out with the bathwater and changing therapies, we zap that one area while otherwise continuing on the same treatment because it seems to be working everywhere else. This obviously is not something you need to memorize, but I show the slide to reinforce how we're improving in cancer in general, and in our approach to lung cancer specifically. And that is to say, when we look at the more recent approvals, it's largely been targeted therapies in orange and immunotherapies in blue, and that we've approved more drugs in the last 5 to 10 years than we had in the decades before that. That the science is really exploding and growing. And so when we think about these targeted therapies, they're approved for a specific genomic alteration. And so these are the alterations that we've have approved therapies for in lung cancer so far. 3 of them are mutations, and then 4 of the genes are ones that are fused or rearranged. Again, that's something more for oncology boards than for internal medicine boards, but I put it here so that when you're seeing a patient, when you're advocating for your patient, these are the kinds of things we want to think about. Unfortunately, these are things that are almost entirely seen in lung adenocarcinomas and not the other histologies. I make this chart for you. Again, this one is not for boards, but when we think about toxicities for different targeted therapies in patients you're taking care of, I thought it was important to get some sense of the side effects, which are listed out here that you can refer to back. But another thing that comes up frequently is drug interactions, and especially because almost all of our targeted therapies are metabolized through the CYP3A4 pathway, all of them except for afatinib. And so this is important to know as you're treating this patient with a calcium channel blocker, you really have to take this into consideration. And then finally, thinking about considerations with immunotherapy. Again, really beyond the scope of this course and this slide to be able to recount taking care of immunotherapy in general, but wanted to make a few points. One is that side effects can occur at any point in the treatment course. So it's not one of those situations where, well, you know what, it didn't happen in the first 3 weeks, so it's never going to happen. No, unfortunately, it can happen in someone who's been on therapy for 6 months. You can get immune-mediated toxicity of essentially any system, though the more severe side effects that we've seen with IO therapy in lung cancer have been pneumonitis, hepatotoxicity, CNS, cardiotoxicity, and Stevens-Johnson's. And then for severe toxicity, important to hospitalize these patients and to call on appropriate consultations early to start them on high-dose steroids, and when more severe, to think about immunomodulators. As with the other lectures, wanted to talk about some considerations during the COVID-19 pandemic, and these may or may not apply depending on where you are in your surge, but recognizing that in some cases it might mean delaying adjuvant therapy. We usually like to try to do it within 8 weeks, but we're willing to, in this setting to move it out to up as long as 12 weeks past the time of surgery. If surgery itself needs to be delayed because ORs are being closed, then instead of giving the chemo out back, maybe we give the chemo up front, just as a mechanism to get them to the OR, hopefully at some point. In potentially resectable stage 3 disease, needing to think about, gosh, if I bring them in for radiation, that means they've got to come in every day, 5 days a week for 6 or 7 weeks. And that every one of those represents a potential exposure. And so that might mean, well, that we think about chemo, neoadjuvant chemo instead of the chemo rads, and think about pushing the radiation till out back after surgery. Or again, if surgery is shut down, then maybe we need to think about chemo rads as the alternative if I can't get them to an OR. Yep. And so you can read the rest of these, which are more pertinent to oncologists, but wanted to make these considerations. And then finally, in summary, we talked about the importance of staging. We talked about the importance of screening and really mobilizing it and how to act on what we find. We talked about local therapies for local problems. Again, anatomic surgery being the key for local disease, and how systemic therapy has evolved to include targeted and immunotherapies.
Thanks so much, David. So we're actually going to hold your practice questions for now to give Dr. Jacobson time for his talk. But there are several questions that have come up in the Q&A. So if you could come back and join us for the Q&A, we'd appreciate it.
Will do.
Great. Thanks so much,
Thanks,
David. It was a lot to cover. And thanks for such a comprehensive talk.